Thank you, and hello everyone. This is Claire Thayer with MCUL, and I'd like to welcome you to our webinar event today, Health Plan Consolidations, Contracting and Other Implications for the New Marketplace. Our speakers today are Jim Donohue and Sherry Griffin, both Senior Managers for ECG Management Consultants. Before we begin, we do have a few housekeeping items to cover. If for any reason you experience technical difficulties with the web portion of today's presentation, please go ahead and print off the PDF version of the presentation that was included with your dial-in instructions. And should you need that link again, it is here. It is http://www.healthwebsummit.com/ECG091015.pdf. And one more time, it's http://www.healthwebsummit.pdf. Our speakers will be taking your questions at the conclusion of the event using the live chat feature. However, now and at any time throughout today's webinar, you are welcome to submit your questions. And as always, if you require any other assistance during today's call, you're welcome to contact the Healthcare Web Summit office at 209-577-4888. Jim, we're now ready for you to begin.
Great. Thank you, Claire. And thanks to those participating by phone and via the web. Over the course of the next hour, Sherry and I are going to be talking with you about what we have seen in working with our clients that has led to sort of the evolution that we've seen in the marketplace and consolidation that's really culminated in the merger or announced mergers of Aetna and Humana and Anthem and Cigna recently, which really to us represents a significant acceleration in the pace of consolidation that has implications that will be felt for provider organizations and for others as these transactions come into reality in the coming years. So we're going to spend a little bit of time going through what we see as the market trends that are relevant to this, that are impacting provider organizations as well as health plans. Focus a little bit on the implications for provider organizations, and then talk about two areas of response that in preparation that we think are important for provider organizations to consider, those related to becoming more like payers in many respects, either in the ways that they are organizing themselves, but more specifically in the context of this presentation, development of provider-sponsored health plans, as well as going through what we see as some of the important tactical responses and planning for more conventional reimbursement contracts with health plans. So going into the trends a little bit, when we view the trends that are relevant in the context of what we're discussing today, don't believe that you can look at the trends related to any particular segment of the industry in isolation. They're increasingly intertwined and overlapping, particularly, we're going to talk about it in the context of provider organizations and health plans, although that analogy probably holds true to many other aspects of the industry as well. When we think about what has been influencing provider organizations in the recent past, we group into four major areas. There are a series of regulatory changes, most notably the ACA, that not only introduced expansion of coverage, but also introduced the concepts through pilots and funding for the development of new and innovative models that would be the path to broader implementation in the future, and we think that future is getting closer. We also have payers or health plans that are responding to the other changes that they're seeing in the market and pressures they're seeing from their consumers, both the patients as well as other purchasers of health care, employees, et cetera, in government entities that are requiring that they demonstrate new and different capabilities in terms of their ability to manage care more cost effectively and at higher levels of quality. And so payers are influencing the ways that they work with provider organizations through new contractual arrangements. You also see consumers entering the marketplace as influencers in ways that they hadn't historically in the past, and demanding and being responsive to price in ways they hadn't been previously, and also demanding different levels of service and accountability. And lastly, you're seeing within the markets that providers are operating significant changes to what in many cases had been long-standing historically stable relationships, clinical and financial relationships within their marketplace. You're seeing those relationships being challenged, and the status quo is no longer the norm. Things are changing fairly rapidly. So in terms of the regulatory, we're going to focus on the reimbursement elements of that. So as I'd mentioned, when the ACA was first introduced, it included some minor, it basically provided some funding which would be designed to incent some directional changes and explore different models for value-based payments. In the last few years, we've seen an acceleration of that, most recently with the announcement by Health and Human Services of their goals over the next 3 years to accelerate and transition the majority of their reimbursement to providers to be tied in some way to alternative payment models which measure quality and cost effectiveness. We also have seen recently the introduction of the mandatory, at least within 75 metropolitan statistical areas, of the bundled payment for joint replacements. And this to us represents a transition from, or the early transition from what had been pilot programs to exploring creation of the new norms for how services are going to be reimbursed by Medicare in ways that are designed to incentivize cost-effective and quality care in ways that we haven't in the past. Now, when we look at the changes that Medicare's made, they also have in many ways opened up the doors for commercial health plans to move in that direction more aggressively. So the fact that Medicare is going to change their incentives from one which is purely fee-for-service into one which is tied to managing total cost of care, or at least in that direction, it opens up the possibility for commercial plans to look to expand their introduction of those types of arrangements in their own ways, in their marketplaces, in ways that would not have been as well received in the past. When we look historically, the changes in Medicare essentially open the door for commercial plans to do the same thing without having incentives that would be contrary to those for Medicare for provider organizations. So this is similarly creating increased pressure for provider organizations to change the way that they're organized, to enhance their ability to deliver and demonstrate and measure their ability to deliver high quality, cost-effective care. So in response to that, within many markets, we're seeing new levels of collaborations and partnerships across provider organizations, in the creation of new ACOs, or clinically integrated networks, designed to bring together organizations which had historically operated quite independently. And as a result, we are seeing smaller numbers of large provider organizations within most markets. And if you look nationally, you also see significant consolidation across markets where you've got the establishment of quite large health systems, which include which cut across multiple geographic regions and oftentimes many states. So they're establishing a critical mass that really hadn't been present in the past, with very few exceptions. Corollary to that, we're also within those markets, it's not just health system to health system relationships, we're also seeing at the more micro level the consolidation of physician organizations and a migration away from the small practice model into either larger practices or more commonly physician employment within a health system or by a hospital directly. Then we also see the proliferation of ACOs, or clinically integrated networks, serving not just government health plans, Medicare Shared Savings Plan or Pioneer ACOs, but also engaging in total cost of care arrangements or other value-based payment arrangements with commercial plans across the country. And these organizations are not just contracting vehicles, they're also establishing many of the capabilities that we have historically seen only within health plans. So the ability to collaborate in the development of care protocols, to develop care management capabilities, both at a centralized level as well as embedded within practices, the ability to examine total claims data, and start to do the examination of managing of a population that had historically been left solely to health plans. So when we think about this, the provider organizations are starting to look increasingly like health plans in many of their capabilities. There's certainly very big gaps in terms of what those organizations look like, but those gaps are becoming increasingly narrow. This slide is a little bit mislabeled. It's talking about provider-sponsored plan. This actually refers instead to some of the trends that we're seeing on the health plan side. So during the same time period, we're also seeing health plans have been responding to the changes that they've been seeing in their marketplace. One way we've seen that is the exploration of many health plans in entering into the provider marketplace and the acquisition of provider organizations or provider-payer collaborations. I think this is probably going to be more narrow, but I think it's more designed, in my view, it's more designed to understand, to develop capabilities in targeted marketplaces and or for health plans to be able to have a deeper understanding of provider organizations and what's required for provider organizations to transition themselves in ways to work more collaboratively with health plans. When we look over the past few decades, leading up to 2014, we did see some trends in consolidation and acquisitions in health plans. The largest, United Healthcare, is the one that accelerated their growth the most and represented the largest health plan by a decent margin nationally. When we look beyond that, the levels of acquisitions were certainly present, but were somewhat more modest. What we've seen, though, in the last year, when we take a look at the announcements that came earlier this year of the planned mergers between Aetna and Humana and Anthem and Cigna, that represents, as I said earlier, a significant acceleration. And when we think about what this looks like in most markets, it represents, at a minimum, a transition to 3 major plans, and in many markets, 2 or 1 dominant plan. And so it's really going to change it has the potential to change the the dynamics within a particular marketplace. In some ways it can open up opportunities in that it'll make it easier if there's a collaborative relationship with the providers in that market. It'll allow them to create greater consistency in terms of the incentives for caring for the population, but it also creates, from a provider perspective, a challenge of having one major plan or two major plans to deal with, and can have some implications from a competitive standpoint. So at this point, I'm going to turn it over to Sherry, who's going to talk a little bit more about some of the implications for providers, and then get into our perspectives on provider-sponsored health plans.
Thank you, Jim. As you can see, as Jim has referenced, the landscape as we know it when it comes to these mergers, with Aetna being at $37 billion if they acquire Humana, and Anthem acquiring Cigna for $45 billion in representation. And we didn't even represent on this slide the aggregation that we see among Blue Cross state plans aggregating into multi-state plans in that regard as well. So we see some significant aggregation across the United States. And we also acknowledge that in the market now, as Jim has referenced, we have governmental payers that are moving their books of business into the commercial managed care realm that will be managed by those commercial payers along the lines of your Medicare Advantage and your Medicaid population. So this gets to be a significant development for the market. If you look at the implications for providers, where these health plans are consolidating and becoming, dependent upon the market, becoming the dominant health plan of one of three, or possibly, as Jim has said, a single dominant health plan, you start to see deeper contractuals expected, discounts expected of the providers. You start to see a more dominant plan that offers a lower premium rate within the market, therefore securing even more market share, which further weakens your provider's ability to negotiate your reimbursement rates in that regard. You also see as the providers are pushing, the payers are pushing on providers to increase their quality and lower their cost. You certainly see that, and providers want to be prepared under the world of ACA to be able to manage and participate in improvements in efficacy in the distribution of health care as well as in the cost of health care. And so you see a greater number of provider claims coming in, reimbursed at deeper and deeper discounts. And some providers will say to me, commercial providers will say to me that they don't really see themselves at risk at this point in time. But if you look at the box on the right hand of the slide, I would contend to you for thought processes that there is a risk involved as the payer goes out and serves as a distribution system into your market, as they're building their premiums, as they are looking to acquire even more market share, and they're factoring those components into your product development and creation of products, then you certainly are at risk for what is provided out there. And I would offer to you for consideration, if you look at your bronze exchange plans right now, for example, the deductibles, the level of deductibles around those plans, that you are certainly at risk dependent upon the product that's being sold in the market and the development of that product. In addition, providers are going to be held accountable for metrics and meeting certain metrics. Certainly health plans get increased premiums when they meet certain metrics, so you're going to see the pressure on you as providers, on the providers to help assist the health plans in meeting those metrics as well. And so certainly the rates and the rates that you're going to be able to secure in the current market may not be as ideal as they once were in the past. So the implications for providers in strategic and technical provider responses. We're going to talk a little bit today about the increased and proactive review of contracts, and we'll do that later on in the presentation. Certainly the acceleration, as Jim has spoken about, in regard to value-based arrangements and understanding how a premium dollar is presented in the market, what that constitutes, and what part of that providers can impact, and then certainly what part of the administrative dollar that certainly you can that you're able to drive under that premium dollar, and we're going to talk in more detail about that as well. And fourthly, the consideration of provider-sponsored health plans. We intend today to give you a sneak peek from with our provider hat on, but from a health plan perspective, and hope that will be beneficial and enlighten you all in regards to how we look at those things. So we've got provider-sponsored health plans. Providers are increasingly looking to be in greater control over the premium dollar. Some of that is being imposed by health plans as health plans start to enter into arrangements that are risk-based with providers and looking to incentivize those providers to act in a certain way, and to have which has implications on lowering the cost underneath the premium structure of the premium of that particular premium dollar. And to maintain financial viability. So we've got the risk is shifting from payers to providers, much as I've referenced already. We have providers that are assuming traditional payer core competencies, wanting to understand the distribution of their product, wanting to understand how the cost associated with that product rolls up into the premium dollar, and then certainly understanding how you better control that, and also understanding how they might share in gain sharing with payers when they do impact and lower cost and increase quality. There's market power from these payer consolidations, as we've referenced, and it appears to be contributing to minimal revenue growth for providers at this point in time. Certainly our market is demanding transparency across the board. Even our governmental payers are setting up infrastructure in which to support risk sharing with providers, as well as transparency when it comes to quality metrics. And those are also being incorporated on the commercial health plan side as well, and then expanded into the governmental payer programs in doing that. Providers are striving to gain better control and understanding over that revenue. Heretofore, it's very interesting that healthcare distribution channels have been controlled predominantly by the health plans, and those health plans have garnered information and data that now providers are striving to get access to in order to be able to impact that premium, the medical component of a premium healthcare dollar, and to impact that, and then to share in efficiencies and effectiveness, both on from a quality perspective as well as from a cost perspective. So to be able to manage those clinical processes and preserve and grow their patient base within their markets. And then we're looking at the opportunity for that provider-payer relationship that is less transactional than it's been in the past, but we are seeing the lines blur in the sense of we see large health plans incentivizing healthcare-based, provider-based individuals to come to their side, and vice versa, as both sides try to understand the other's world and try to bring this into focus and work in order to lower cost within populations, improve quality, lower cost, and then distribute that to the market. So I wanted to share with you just a little bit how a premium dollar splits up. So if you'll look at this, schematic here, you'll see that the reimbursement is shifting from volume to value. We know that, and that is not only being driven by the commercial insurance companies, that's being driven by the governmental as well. So it's pretty much in every payer component of the provider's market, and that is being split up. And here you see that typically on a premium dollar, 40% of your hospital has been attributable to your hospital, with around 28% on this to physicians, and then you've got your pharmaceuticals and some other medical services, and then admin cost. with ACA, there was a mandate that you have an 80% or an 85%, depending upon if you're a large or small group. And so that allows you to these are medical loss ratios that you have to meet. And if you do not meet them, if you come in under, then you have to give rebates back to the payer population in doing this. And so we're starting to see non-traditional components of the premium dollar being increasingly important to the providers, not just the medical component, and providers wanting to understand this. And on the flip side of that, quite interestingly, we're seeing payers that want to understand the provider side world better. So we see those lines absolutely being blurred along between the constituencies here. So I wanted to show you today within a provider-sponsored health plan and just give you an idea about the initiatives. And we've seen this historically come to pass in payers looking to lower the cost association because the cost curve is no longer sustainable within the healthcare industry. And so therefore you see the ED expense here. We're seeing ED expenses go down and inpatient expenses go down. Those visits go down as we start to see medical management components come into play. As healthcare providers are partnering with payers and they're working together to decrease the utilization. This can be a good thing if you're on the payer side. It's not necessarily always a good thing if you're on the provider side. So we're starting to have to understand each sides of this coin in order to come together and manage that cost curve that I referenced a little bit earlier. So within provider-sponsored health plans, we have seen those in the past. We've seen a great deal of those in the past, and they were before their time, quite honestly, I think. So what we saw in the past is that providers really saw the health plans and their involvement in a provider-sponsored health plan to be a conduit to just fill hospital beds. Now that we see the dynamics changing of our payer market changing, governmental business moving steadily toward with goals of as high as 80% of that business being moved into a more managed environment, we're starting to see that the payer and provider side come together more. So you see the reimbursement implications on this slide that I'm referencing at this point in time, that you've got a resurgent in provider-sponsored health plans or partnerships, whether it be owned or some type of partnership or start from the ground up. We see these developing, and we see a resurgent in these developing as there is an expectation that the providers want to be more involved. If they're going to be accountable and responsible, they want to be more involved from a health plan perspective as well. In that regard, we've got a value proposition here. We've got the growth and distribution channel to enter into our new markets. It diversifies revenue streams. The health plan can serve as a strategic advantage for provider organizations to help assist them grow. Not only do we anticipate that, obviously, with these mergers, that we anticipate partnerships at various levels, we also consider the possibility that as providers get more attuned to the health plan aspects, they become stronger partners in going to market and in being able to address costs associated with that. So you see that we have growth and distribution channel to enter into the new markets. Certainly it diversifies our revenue streams as providers if we're provider sponsored, and it allows us to enter into new potential revenue streams on behalf of the providers. There is a focus there on population health wellness management that's supported by good actual claims data in these types of partnerships. We're able to look at the premium dollar. We're able to try to better manage the premium dollar, understand the entire premium dollar, and create a better, with these partnerships, we are able to create a better plan and a better connection with patients and with managing the actual needs of the patient population. So understanding both provider and health plan operations serves us well in today's market environment. So in that regard, we have provider-sponsored health plan growth. We have actually even more than 300 at this point in time. You see that in 2012, 62% of the top 100 integrated not-for-profit health systems have the health plans. And each one, as each employer, we recognize every employer, including health systems, operate their own health plan, and that's usually a substantial part of their budget. And that does not go without notice from senior executives that are operating within healthcare systems in managing the cost of their own health plans. So we see that there are 4 primary population products commonly being considered a startup, and those are their own employee health plans. And certainly you get an upside of the learning process around those, and you also get reap the benefits on lowering your cost around your own employee health plans as an employer from that perspective. In addition, we see Medicare Advantage coming into play, as well as self-employed direct-to-employer narrow networks around the large self-funded employers. And then, of course, the health exchange products that are have come into the market, being able to address the needs of that particular population that's relatively new and has a substantial uninsured population heretofore within that. Secondarily, here we have what we have here is, I'd like to just point you to the right-hand side of this diagram and talk a little bit about the risk sharing. We certainly have expertise in the other areas around that, but our funds flow and distribution, as well as our premium pricing, benefit, and product design, within the risk sharing, these are aptitudes that typically health providers have not well understood and have not been heavily involved in. These are the functions that benefit and certainly drive the health plan designs, and obviously the cost of the health plan and the management underneath the health plan. So that is key and core to that health plan dollar that we were talking about earlier and that I showed you earlier.
Okay. Thank you, Sherry.
You're welcome.
So the last thing we wanted to talk about was really more tactical than strategic, which is when we think about, in the way this is going to look is going to vary quite a bit by market. But it's our opinion that in anticipation of the mergers between Aetna and Humana and Anthem and Cigna, it's important for provider organizations to be proactive in understanding what their existing contracts are, what their requirements and liabilities and options are within the terms of their current contracts, and what the implications would be if there were a shift of population across different products that they may have contracted for within their marketplace. Let me just talk quickly. I'm going to talk in the next few slides about the types of things that we're recommending organizations do to be prepared for this. And we would suggest that this process begin. There's no reason it can't begin now, so that you're prepared and you don't miss out on opportunities to avail yourselves of any options. So the first thing is do a proactive review of the existing arrangements or existing agreements with those 4 health plans. Simply taking a look at the overlapping products that are licensed by that health plan, both those that you're contracted with, as well as developing an understanding of what they're licensed for within that marketplace. Identify overlaps in products across the merging health plans, and then develop a process to help yourselves manage and track those, the enrollment and membership in your payer mix over time, so that you're very attuned to changes. The next part would be making sure you understand where there is variance in the rates that are existing between the plans. So if you have significant variance between your Anthem and Cigna contracts, for example, does that create a vulnerability for you if you are not able to manage, or if the membership is transitioned from reimbursement under one plan to reimbursement under the plan that's less favorable. It's important to understand what that variance is so that you can understand the degree of liability you could face if you were to see a transition of membership across products. In some cases it can be significant if you've been successful in creating parity across your plans. This may not be such an issue, but it's going to be important to understand. The next thing would be understanding the contract language and the options that creates for you or for the health plans. Would suggest is, this is fairly tactical, creating a matrix of some key contract terms by health plan and by product. The things that we would encourage you to include at a minimum would be termination and renewal dates, so not just the expiration date, but what are the renewal dates? What are the key milestone terms? Does it go into evergreen automatically, as most contracts would, or does it require renegotiation at the expiration? What are the notification requirements for termination or for initiation of negotiations? Some of the contracts you'll find will have requirements that are 18 months in advance of, or 6 months, not usually 18 months, 6 months in advance of the scheduled expiration or anniversary date of the effective date of the contract or of the termination date of the contract. And if that notification is not provided, you automatically are renewed for the next year. What are the provisions related to assignment of the agreements by either party? What are the provisions related to changes in ownership? And you'll find that the different contracts handle these things quite differently. If you've got contracts or base agreements which have been in place for quite some time, they may not be, the language related to that may not be as robust. The more recent contracts or more recent base agreements tend to be more explicit in terms of the rights of the various parties or obligations associated with the change of ownership or the introduction of new products. So it's important to understand what are the key triggers and what are the options for the plan or for the provider organization to either allow or prevent or does it require approval to make these kinds of changes in terms of where under what products the patients are covered or under what product the reimbursement is based. And lastly, what are the provisions related to adding new products? So you could see the introduction of new products as well. It's possible that there would be. It's probably more likely in most markets that the business would over time consolidate into one plan. But there is also the possibility of the introduction of new products or introduction of products which might be licensed in a marketplace, but that they would look to transition members into those new types of products which you may not have focused on historically. And lastly, develop a plan of action. So we'd suggest organizations spend the time in rigor to go through your agreements right now, understand what your liabilities, what your options are, what the timing is, set up an approach for tracking changes over time, and develop an action plan based upon the circumstances in which you find yourself. Other part is proactively communicate and develop relationships or leverage existing relationships with representatives from the health plans and clearly communicate what it is that you're looking to achieve in the relationship with them over time. That's likely to put you in the best position to understand what they're thinking and to work collaboratively with the health plans in ensuring that you can be a good partner for them, but also that you protect the provider organizations protect their interests. So with that, I think we will pause. Sherry, did you have anything you wanted to say in wrap up before we head to questions?
No, I think you covered it. I do think that doing an assessment of your current relationships, the market share of those relationships, looking at your contracts and doing a matrix in regards to what each contract requires, and some of these data elements that we've given you is an excellent start in looking at developing your strategy around how you're going to address these changes in your market.
So we're available to take questions now. I believe that for those of you participating by web, if you can type in questions in the chat section, we'd be happy to respond. I know there is one question out there about the copy of the slides. I think there's Claire, I think you or someone else will respond to that. I don't see any questions.
Okay, this is Claire back on the call too. So I'm just going to advance a slide for you to your Q&A section here. Jim and Sherry, if you while we're waiting, it looks like a couple questions are coming in now. So go ahead and take a look at that.
Okay, Jim, would you like for me to take Margaret's question?
Sure, that would be great.
Okay. Margaret's question is, what experience have we had with physician groups negotiating directly with self-funded employers? We've had some significant experience with self-funded health plans and physician groups negotiating directly with self-funded employers. Typically, though, self-funded employers are looking for broader networks, all-encompassing, but there are those points in time where you can strike deals specifically with some large self-funded employers within your service areas to allow you to connect with them and work on certain initiatives together. And we have seen some of that within the markets. Jim, did you want to respond to that?
No, I think you covered that one. We did have a second question as well. Margaret, I think you asked a follow-on. I couldn't quite understand. I think there was some mistyping. So Margaret, if you could retype your follow-up question,
right.
I'd be happy to answer. But in the meantime, I'm sorry, Sherry, do you want to take the follow-on question from Margaret, and then I'll answer Dwight's question?
Let me see if I see it. Oh, examples of experience. Margaret, your question is examples of our experience. We've had experience within, we have the level of being within our organization of individuals that work directly with self-funded health plans, as well as served as at the capacity of CEO of self-funded health plans, and both within health systems as well as in the outside market in regards to large self-funded employers of various kinds. Margaret, did I hopefully I answered your question. If not, please pose it again for us.
In the meantime, let me see if I can respond to Dwight's question. So we received a question that said, if a provider has an existing agreement with Humana and Aetna, once they merge, which contract terms, parenthetically pricing, will be the primary? So on day one, or what I would look to would be examples of prior mergers as examples for how this might be handled. And so it can vary. It depends on the strategy that's employed by the health plans. But On day one, they will have 2 licensed products within a particular market. What they have the option of doing is looking over time to bring those together, and it depends on a lot of it is going to depend on how they contract for their network, as well as the specific terms within their agreements with your provider organization or with each provider organization. So when I say how they contract with their network, so for example, if Humana in a particular marketplace, or if you have a health plan which leverages a secondary or wrap network within a particular market. In other words, they have not directly contracted for providers, but instead utilize another rental network to provide coverage in that particular area. While Aetna has direct contracts, in that situation it's quite easy for the transition. Essentially, under that scenario, all that would be required is Humana could cease to use that other third-party wrap network and instead access the network through Aetna. And in doing so, it would transition over into the rates of Aetna. In the scenario where they both have direct contracts, it's a little bit more complex, but and it would be more likely that there would be a termination of one contract or another, with the idea that the networks would merge over time, and that timing of that would also be dependent on renegotiation communications of the health plan with the purchasers, most likely employer organizations, for their services. So I don't know, Sherry, do you want to add anything on that one?
Yes, I think certainly from a provider perspective, I think certainly you want to go in and look at both of your contracts and see what's required of a payer prior to merging. If there's notifications, and outline that. Certainly having the conversations with your payers as well to go ahead and upfront establish expectations around timing. I think for a while you will see some of these payers that will have more expertise on, say, governmental versus commercial, and you may see them stay under their existing paper, because it will take them a while to merge all this together as well and to start to look at that. But I think starting earlier rather than later in understanding the relationship and communicating around the relationship is going to be key to understanding the nuances and specifics to your market. Do we have any other questions?
So Jim and Sherry, this is Claire again. I don't see any additional questions, so I want to have any concluding remarks, and then I'll step in again.
Jim, would you like to lead, and then I'll wrap up?
Sure. I well, thank you to MCOL for providing the opportunity, and thanks for the participants for your time. I hope this has been helpful.
And I just agree, and we certainly appreciate the opportunity to present to this group today. And any additional questions you think of when you get off of this call, certainly we'll be glad to try to answer those. Thank you.
Okay, thank you. And this is Claire again. And we'd like to, here at MCOL, would like to take this opportunity to thank both Sherry and Jim for joining us, and the session participants for joining us today. We will be sending a feedback evaluation form via email at the conclusion of our webinar, and we'd love to receive your feedback. This is already also a great opportunity to submit any additional questions you may have for the speakers. If any questions came in that come in as we're concluding here, we'll go ahead and pull those off and be sure to forward those to the speakers as well. And if you haven't already done so, we do have a LinkedIn group on the web where you can post questions and start discussions or suggest topics for future events, and we'd love to hear from you there as well. This now concludes our webinar.